Hello cruel world, my name is Dr. Sohom Das. I'm a consultant forensic psychiatrist. I assess mentally disordered offenders for a living so that you don't have to. So today I'm going to talk about a real life incident. In July 2015 there was a siege at the John Howard Centre, which is in Hackney in London. It is a forensic unit that is made to treat and rehabilitate mentally disordered offenders. During the siege, some staff were trapped. I actually used to work at the John Howard Centre roughly between 2011 and 2013. In this video, I'm going to answer the following questions. First of all, what happened with the siege? Then I'm going to tell you about another incident that happened that same year where a prolific burglar escaped the John Howard Centre. And I'm going to explain why after the siege, some of the patients went to prison and some went to Broadmoor High Secure Hospital. And I'm also going to tell you my whole thoughts and experiences and conclusions about the whole thing. So firstly, what is the John Howard Centre? It's named after John Howard, who is an English early prison reformer who was alive around the 1700s. It is a medium secure unit, so most of the patients in there have some form of mental illness and have committed either a serious offence, so the illnesses might be anything from schizophrenia is very common to bipolar affective disorder. The offences are usually either violence or sexual violence, occasionally arson, etc. And although most of the wards are mental illness wards, it does have like a specialist personality disorder unit, and it's also got a learning disability unit. I've talked about these diagnoses in my other videos, go check them out. And at any given time there'll be roughly a couple of hundred patients within the unit on separate wards which have roughly around 18 patients on each. And the patients usually come from prison, either like during their trial or after they've been sentenced, or they come from court during their criminal process, which is the kind of stuff I give evidence about currently, or occasionally they come from other units, so they come from like low secure or general adult units where their level of aggression and violence is so high that these other units just can't cope, so they need to go to a medium secure unit which has extra levels of security, which I will tell you about later on in this video. The other thing I'd say is that all medium secure units, all secure hospitals including Broadmoor, are geared for rehabilitation and treatment. So it's different from prison. Prisoners are locked up most of the time and they're being punished, and there is some rehabilitation there to try and give them the best chances of coping after release, but the difference is that these hospitals are there to treat something, specifically mental illness, and only lock people up if absolutely necessary, for example if their violence is uncontainable. So what kind of security do you have at the John Howard Centre, or for that matter any medium secure unit? Well, first of all, there's a big high wire fence. I believe it's 2.8 meters minimum height, and it's kind of climb proof, by which I mean the gaps are really small and it's kind of hooked at the top so that patients can't climb over. All the doors are locked, and the staff in the John Howard Centre at least have a fingerprint scan that will scan your thumbprint before you can pick up your keys on the way in. Some of the older units you just have a passcode to get your keys. And there's also an airlock to get in and out of the John Howard Centre. So what an airlock is, in case you don't know, is like two locked doors with a big sort of perspex room in the middle so that security staff can see anybody that comes in. One door gets locked, they check their IDs, and then the other door gets open and then staff go through. Or if patients are coming and going, for example on leave, then it's all signed for and the security staff can see exactly who's coming and who's going. The whole point of an airlock is it's not just one door that can potentially be bolted through. So those are all security measures to stop escape. There's also security measures to stop violence. Specifically, all the nurses carry around, or in fact all staff carry around alarms. So if you pull your alarm, it's kind of radio activated and the security team will know exactly where the incident is occurring if you need backup. And for example, we have seclusion rooms. So if a patient is very violent or agitated, then they're locked in what colloquially used to be known as a padded cell, but it's like a secure room. I have done videos on how violence is dealt with in these units and how it's treated on a long-term basis. That's within my series on Broadmoor high-profile patients, so go check that out. The one thing that I would say is that unlike what you might see on TV, the vast majority of security and like restraint is actually done by nurses, by ordinary nursing staff, not security guards. So when I said before the security teams, I meant an emergency nursing team made up of nurses. Places like this might have a small security department, but there's only 2 or 3 people, unlike what you see on TV where all the nurses are, these massive muscle-bound, basically brawlers who are ready for a fight. It's not like that at all. Your average restraint is done by your average-shaped, nurse. So, going back to the siege, exactly what happened. So it was on the 3rd of July 2015, and what happened was that 6 members of staff were kind of barricaded in their office whilst 5 patients brandished broken glass. Then the police were obviously called, and there was a bit of a standoff with the police. I believe that some of the patients hurled missiles. I always wonder why they call them missiles, because I've always thought of a missile as whoosh, with like fire come out the back, but anything you throw, I guess, technically can be a missile. It wasn't a hugely serious incident in that, as far as I'm aware, nobody got seriously hurt and nobody actually escaped. But after the standoff with the police, 5 patients were detained. 3 of them were arrested on public order offences and sent to prison, and 2 of them were sent to Broadmoor, which begs the question, why were a couple sent to Broadmoor and 3 sent to prison? And that's basically, there's a lot of factors. So the first factor could be what section they were on in the first place. So for example, they might be on a section 48, which means that no decision has been made about their long-term treatment or detention, whether it will be in hospital or prison. So it's pre-trial, and the psychiatrist and the judge are still trying to figure it out. So if somebody had a siege and they're pre-trial, then the chances are they're going to be thought to be too dangerous to be in a psychiatric unit, probably sent to a prison for remand, will still go through their trial. Or they could come from prison on a section 47, which means they've already been sentenced and are just there for a temporary period of time to fix their mental state with the intention of eventually getting them back to prison. So if I was a psychiatrist working at the John Howard Centre and my patient was getting better anyway and had an incident like this, I would think, right, they need to go to prison because the security in prison is better. Or they could be on a section 37, which means that they're actively mentally unwell and likely to be mentally unwell in the long term for years, probably need years of rehabilitation. So unlike those other 2 sections, the plan is to treat their mental illness, through medication, psychology, etc. So in that situation, they're more likely to continue needing treatment. But if they're doing things like sieges and throwing missiles at police and threatening staff with glass, then they need a higher level of security. Hence the move from John Howard Centre, which is medium secure, to Broadmoor, which is a high secure hospital. Broadmoor has a much higher level of security, more fences, more doors, more staff to patient ratio, really thorough checks in and out of the building for staff and patients. The interesting thing about Broadmoor is most patients step up due to violence, although there are some special circumstances where a patient's not necessarily violent, but their level of other types of risk are so high that they need to go from medium to high secure. So to give you examples, if somebody's a prolific escaper, just constantly trying to run away and is quite successful, then even though they're not violent, their level of security might go up. Or if somebody starts fires, so they might not be violent to other people, but obviously starting fires is extremely potentially serious, they might get shipped off to Broadmoor. Or if somebody's like gang affiliated and there's a risk that their gang, their buddies might try and break into a centre to try and get them out, that's another reason that they need a higher level of security. That might sound kind of insane, but I've seen it happen. I rephrase that, I've known it to happen once in a psychiatric unit I worked in Australia. It was during the weekend, I wasn't working, but a Lebanese gang went in, slapped around a few nurses, rescued their patient and bolted. Reminding me a little bit of Murdoch from the A-Team. Okay, I'm going to briefly tell you about another incident which happened also at the John Howard Centre, also in 2015. So there's a man called Peter Carrigan who was an Irish traveller, and he was dubbed by a judge to be the most prolific burglar in Britain. He'd apparently broken into 1,400 homes by the time he was 17, which is mind-blowing. It's actually quite impressive on some levels. So in 2015, he was having escorted leave from the John Howard Centre, so that means that either 1 or 2 nurses would have been with him whilst he was on leave, and he basically bolted. So he didn't physically escape from the building, which is kind of important, and I'll come back to that. And he was on the run for almost 6 years, and the reason he was caught was because he tried to commit a burglary on a pensioner in Hampstead, which is kind of a posh area of London, and his face was recognised on the camera on that person's doorbell. He was eventually caught and he was sent to prison, and the John Howard Centre started electronic tagging some of their patients on leave after that incident. Okay, so I've told you about things that are already out in the public domain, so by the way, I'm not snitching on my brethren. Just very briefly tell you about my experience of patients escaping. So in my time of working in secure units, I think I've heard of 3 times that I've known of a unit that I personally worked in of patients escaping, and I think all 3 of them were during leave. So if it's during leave, it's a lot easier to escape because you don't physically have to break out of the building. You're either on escorted leave, like Peter Carrigan was, and you can just leg it, or unescorted leave, which means that you're kind of already given a level of trust and you're deemed as relatively safe, and then you just don't come back in time. So arguably the patients that are already on leave are not deemed very high risk, because the consultant forensic psychiatrist has already thought that they're safe enough to at least be in the community. It's the patients that escape physically from the building that you have to worry about more. In the 3 cases that I know about, they were all very short-lived. So the patients were returned, I think a couple of them were within a couple of days, and one of them was around a week, maybe a week and a half. So cases like Peter Carrigan, where somebody goes on the run for 6 years, is extremely rare. And I think the reason for this is because firstly, we know a lot of information. So we know where patients live, their home addresses, addresses of their known associates, etc. So the police have this information. It's not that hard to find them. And also because most of the time when patients escape, they just want to go on a drugs binge. So that happened in the cases that I was talking about. They've been locked up in this hospital, which to them probably feels like prison. They just want to let loose and go on an alcohol or drugs binge. So they're not trying to go on the run, or they're not trying to escape. They just want to have some fun, knowing probably in the back of their mind that they're going to be caught. Okay. Before I tell you my final conclusions and thoughts about this whole situation, I want to quickly introduce you to this channel, A Psych for Sore Minds. I'm your host, Dr. Sohom Das. I'm a consultant forensic psychiatrist. I work in prisons, I work in court, and I work in secure psychiatric units, assessing mentally disordered offenders, units like the John Howard Centre. This channel has a whole range of videos, all related to mental illness, some related to offending and violence, because that's my speciality. I look at high-profile real-life cases and I dissect them with my own psychoanalysis. I look at individual diagnoses, I interview people, I talk about my own real-life cases, but I anonymize them out of respect for patient confidentiality. To conclude, I'm going to give you my kind of professional thoughts about this whole situation about the siege. I don't want to minimize what happened, and I imagine those members of staff must have been very scared. They must have been fearing for their lives and their safety at that time. But I still don't think it is that severe an outcome. So nobody actually got hurt, nobody actually escaped. And you have to remember that these units, medium secure units, are full of people with a history of violence, and it's not that uncommon for other incidents like fights or assaults to occur on the units. So to put it in perspective, it shouldn't have happened, but I don't think it was that big a deal. It's not the worst outcome that could have happened. If you think about it, there's hundreds of patients and the turnover is quite high as well. So patients come and go every couple of years. So over the space of, 5 years, there might be 1,000 patients that go through. So it's actually quite rare. In the case of Peter Carrigan, one question that you might reasonably ask is, why didn't the nurses stop him escaping? Which is a fair question, but it's quite hard. So if you're out on a public street, and I know that the John Howard Centre is really near a built-up area in Hackney, and there's high streets nearby, if somebody bolts, then it's quite hard to catch them, especially that if you're not necessarily that athletic. And also, you might be like a larger female nurse, and they might be a young athletic man. You might get yourself hurt. And as I said, most times patients are caught within a couple of days. So I think instead of proportioning any blame to the nurses who are escorting, it might be a bit more reasonable to think about whether Peter Carrigan should have had leave in the first place. So at some point, a consultant has to make a decision about whether their patients are safe enough to have leave. And it's easy to point the finger, but firstly, you have to discharge patients eventually, because if you just kept all patients there for the whole time, then firstly, there's not much point in them being in hospital. You might as well have them in prison. And secondly, it clogs up the system. So you need to move patients on so that new patients, and there are many, many patients in prison who are floridly psychotic, who need help, who need rehabilitation. You need to move patients on so that they've got spaces to come in. So at some point, you have to take a positive risk and allow leave to patients. And you can only really go with what's in front of you. So I don't know the details of Peter Carrigan's case individually. I've not seen his case file. But if he was listening to all the rules, if he was not causing any aggro on the ward, if he was taking his medication, if he was engaging in therapy, and if he was planning to escape, so I don't know whether it was pre-planned or if it was impulsive, we would never know. We can only go on the behaviour and the risk factors. So, as long as these things were considered carefully, as long as the consultant looked at all the different aspects and discussed it with their team, then I would argue that it's not really their fault. It's their responsibility, but it's not really their fault because you don't know what's in the mind of anybody else. Even the best psychiatrist in the world, which I'm not, cannot know the thoughts and intentions of somebody else. So those are my final thoughts. Before I go, please subscribe to this channel. I've got loads of content. There's something for everybody on this channel. Stay euthymic, and whatever you do, do not forget, I love you.